take your number and I'll call you. I have your number. I'll call you. I was also very keen that we must meet at least on Zoom platform.
Sir, we are live now to the audience, sir.
Sure.
So we'll start, sir. Yeah. So very good evening to the experts who have joined on a Monday evening and given us this opportunity to have a discussion on the RAS blockers, the role of RAS blockers, how they have evolved in the post-MI space, starting from the age-old trials of SAVE trial of enalapril to the recent Paradise MI trial, and who better than Dr. Ashwani Mehta, sir, who has been the investigator to the trial, and it will be a real privilege for all of us to take insights from this expert panel. So without further ado, may I take this opportunity to initially introduce our esteemed faculty of today's program. To begin with, the moderator for today's program, Dr. Ashwani Mehta, sir. Sir requires absolutely no introduction, not only just in India, elsewhere as well. He's one of the senior most luminaries in the field of cardiology. He's a director of heart failure program and research, Sir Gangaram Hospital at New Delhi. I welcome you, sir, and thanks for giving us this opportunity.
Thank you.
We also have with us, and I would request all the members today to join us in welcoming Dr. Shailendra Trivedi, sir, who is the senior interventional cardiologist from Indore. He is practicing as a director in the field of cardiology from Vishesh Jupiter Hospital. Thank you for your valuable time, sir. I welcome you on board. And last but not the least, we have Dr. Gaurav Khandelwal, who is a senior consultant and interventional cardiologist from Bhopal, who is working at Apollo Sage Hospital. I welcome you, Dr. Gaurav, sir, for this valuable and insightful discussions which we will be having in the next 40 to 45 minutes. And the agenda for today's program, as I've discussed, as I was mentioning, RAS blockade, the role in the acute MI space and how they have evolved. And do we have a verdict when we speak about individual patient profile and what will be the best option or a drug which has to be used in that particular patient profile? A request to all the members who are joining in as our audience, if there are any queries, please post your queries in the chat box so that our experts can share their views once we get time during the panel session. So with this, I take the opportunity to invite Dr. Ashwani Mehta, sir, and over to you for further proceedings, sir.
Thank you, Dr. Anoop, for giving me this opportunity. I think for me, it's a great pleasure to be with my old-time friend, Dr. Shailendra Trivedi, and also another young cardiologist, Dr. Gaurav Khandelwal. And I'm sure with the experience which we have today, it's going to be a nice session. And to take this forward, we all know that today, as far as RAS blockade is concerned, there are certain areas where clearly ARNI is of great benefit. And in HFrEF, it's been done and dusted that the ARNIs are superior, but still, we have a long way to go as far as ARNIs are concerned. And to shed light on the RAS blockers, what is the present scenario in acute myocardial infarction? And the evidence we have from the various trials, right from the beginning of the trials in this space in the form of SAVE trial to the Paradise MI, do we have the verdict? That is what is, we'll try and find the answer to this, that is the verdict there. So post myocardial infarction, we all know that RAS blockade is important. And this is in addition to the MRA and the beta blocker. And the RAS blockade, typically, whatever is the scenario, evolves around the three group of drugs, the ACE inhibitors, the ARBs, and the ARNIs. And we'll also have a look at the guidelines, present guidelines, that what do they suggest? So if you look at the ACE inhibitors, right in the beginning, number of trials were done about more than 2 decades back. And one of the first trial which was done was with captopril. And it was a radionuclide-based study done in patients with ejection fraction of less than 40%. And here, the captopril target dose was 50 milligrams 3 times a day. And about 2,231 patients participated, and it was started 3 to 16 days after myocardial infarction. And they did a MOGA scan, and the patients who had no symptoms of heart failure with ejection fraction of less than 40%, so they were given this particular drug, and the average follow-up was about 42 months. So quite a long follow-up. Then we have the AIRE study, which was done with ramipril, and this was again with the 5 milligrams BID dose and 3 to 10 days after myocardial infarction in patients with evidence of heart failure, whether it was clinical or radiographic, and interestingly did not had any echo criteria. Then we have TRACE trial with terendopril, 4 milligrams. 4 milligrams once a day was the target dose, and 3 to 7 days after infarction. And here patients with evidence of reduced ejection fraction, which is less than 35%, were taken. And here again, the follow-up was from 24 to 50 months. So if you look at the SAFE trial, the first trial to have a look in this particular group, and as the name suggests, the survival and the ventricular enlargement study, that is what it was looked at. And what it showed that when captopril was given as compared to the placebo, there was a 19% reduction in mortality and 25% reduction in the recurrent myocardial infarction. And it also showed that the left ventricular cavity dilatation was reduced. And these benefits occurred equally in patients who received thrombolysis plus beta blockers and also those who did not. So first trial to lay the foundation of the RAS blockade in post-myocardial infarction was this. And then the AIRE study, which was acute infarction ramipril efficacy study. And it showed that the ramipril group, 27% reduction in mortality and 19% reduction in rate of MI and stroke at 6 months was seen. We had extension study of this, and which carried on in 603 patients, which was a subset of the earlier study. And the beneficial effects of ramipril, when started early after MI with heart failure, are sustained over 3 to 4 years, despite discontinuation of medication at 1 year. Now, this was very interesting. So what it showed was that, one, you should start it early, and the benefits continue to occur once it was stopped after 1 year. So there was something to do with the remodeling probably, which improved the left ventricular functions and which persisted. So very interesting study, because before this, the concept was to introduce after 3 days when patients were relatively stable. But this showed and paved way for an early use of ramipril with benefit. And terendopril again showed a reduction of 25% in mortality, 15% of recurrent MI, 20% in SCD. So all the drugs, as far as the ACE inhibitors were concerned, did show benefit. We also have evidence from the other studies like the ISIS-4 study, the GC3 and the CCS1. And interestingly, in the ISIS-4 study, the captopril was effective in reducing 5-week mortality. Lisinopril in GC3 showed that if started within 24 hours after MI, there was an effective reduction in mortality and incidence of severe ventricular dysfunction. CCS1, they were huge trials. Number of patients in ISIS-4 was about 60,000, GC3 nearly about 20, and CCS1 about 15%. And here, again, it showed that in patients with anti-reval MI, captopril reduced the benefits. We also have the ARBs and 2 big studies, one optimal and another valiant. Now, interestingly, on one hand, we have seen that the ACE inhibitors somehow have some kind of a benefit which is there. And the ARB trials, if you see here, optimal and valiant both, it did not show any difference in mortality, whether it was losartan or whether it was valsartan. So in the space of post-myocardial infarction, these did not show. And if you look at the optimal trial, which was done with losartan, they did not find any difference in mortality, as you can see from the graph. And what you can see here is that the ACE inhibitors, what it clearly showed was the ACE inhibitors were superior to losartan, and the ACE inhibitors should remain the first choice of treatment in patients complicated with acute MI. And it should not be recommended post-myocardial infarction. And the Valiant trial, this was done with a lot of thought and here, interestingly, there were 3 arms: captopril, valsartan, and also a combination of valsartan and captopril. So what it showed was that mortality from any cause or cause-specific mortality was similar in all 3 treatments, and the rate of secondary endpoint of death from cardiovascular causes, recurrent MI, hospitalization for heart failures was similar in 3 groups. But later on, we also learned that if you combine ACE with ARBs, then you have a higher risk of hyperkalemia. So with this background, now I would like to ask Dr. Shailendra Trivedi, who has a huge experience in this group of patients. The first question would be that ACE versus the ARBs. What is your preferred RAS blocker in ACS? Whether revascularization procedure was performed or not. So what exactly is your choice of the RAS blocker in these patients, and whether it is influenced by revascularization procedure or not? So Dr. Trivedi, if you could take it from here.
So the data which you have presented just now from various trials and from our experience also, I can very confidently say that AC inhibitors should be the first choice in post-MI patients, whether we do revascularization or not. So I think that message is very clear in my mind that the preferable drug would be AC inhibitor only, and only if the guidelines also say that if the patient is intolerant to ACE inhibitor, then only we should give RAS, this ARBs. So it's very clear evidence that ACE inhibitors are the winners as compared to ARBs in patients post-MI with or without revascularization.
Yeah, thank you so much. What you said, I think I would echo the same sentiment as you said, and I would also agree with what you say. And let's look at the evidence about this. And if you look at the evidence, then clearly we know that the benefits are there. And now I have another question. This is to Dr. Gaurav. That do you switch to an ACE inhibitor in your post-MI patient if the patient was already receiving an ARB for his or her hypertension treatment? So Gaurav, let's have your answer for this.
Sir, I in my practice generally won't switch, because if you look at the data also, the comparative data, it says that ARBs are non-inferior to ACE inhibitors, but it doesn't say that ARBs as compared to placebo are not working. So, generally, if there is no reason to change the medication, for example, if a patient was already taking telmisartan, I would rather continue the patient with telmisartan and add beta blocker to it.
Okay. So that is a very interesting piece of information, and you've added, and we'll have a discussion on it later. And so you are certain that if the patient is on ARB, you would not like to switch it to an ACE once the patient has had a myocardial infarction. Thank you. So we have evidence from both these, and we also now have evidence for ARNI. And I had the privilege of being part of this trial, which was looked at in the Paradise MI, and for the first time, we were very excited that even in the space of post myocardial infarction, maybe we have some kind of evidence of benefits of ANI. And I'm going to show you some results, the primary results of the Paradise MI trial. And this was done in patients of acute myocardial infarction. And we know that now we are certain, and we have evidence that in patients of acute myocardial infarction, the benefit of using the ramipril tends to be there if we use it in early part, which is maybe even earlier than the first 24 hours. And similarly, in this trial, the inclusion criteria was such that patients with acute myocardial infarction, within the first 1 week, with ejection fraction of less than or equal to 40% with or without pulmonary congestion were taken. But they had to have any other risk enhancer, which is the age more than 70 years or a EGFR of less than 60, diabetes, history of prior myocardial infarction, atrial fibrillation, LVEF less than 30, CLIP class more than 3, STEMI without reperfusion, and there were exclusions. The exclusion was if the patient had prior heart failure and had a fresh MI, and also if there was a clinical instability, and also if the EGFR was less than 30. And they were randomized either to ramipril or to sacubitril/valsartan. And ultimately, the target was to reach the BD dose of ramipril 5 milligrams, and similarly for sacubitril/valsartan 200 milligrams twice a day was the target dose. And in both the groups, there were about 2,830 patients, and the events were looked at, the primary events of CV death, heart failure hospitalizations, outpatient development of heart failure, and also the secondary endpoint of CV death or first hospitalization for heart failure. So this study was done in all over the world, and we had a representation from almost all the major parts of the world. And of course, India also participated in this study in a big way. And I think we were number 3 or number 2 in the number of patients which we recruited. And what we find here that if you look at the matching, then both the groups were very well matched. And here, whether the patients had a PCI or lytics, so they were well matched. And if you see here, typically it was a present day study. So it had a very less incidence of patients after thrombolysis. So out of 2,830, the percentage of lytics was very less in both the groups. And also the patients which were taken, they were very well matched. Like they were on dual antiplatelets, and about 85% patients had beta blockers, and aldosterone antagonists were also there, statins high dose. So most of them were already on good drugs. So this is what is the primary outcome slide. And if you see here, the CV death first hospitalization for heart failure or OPD based heart failure event, which was also mapped in this, you could see that the differences between the two curves was not much, and the p-value was 0.17. The hazard ratio was 0.9. The events were little less with sacubitril/valsartan, which is 338 versus 373 with ramipril. But if you look at the statistical significance, it was not reached, although the hazard ratio was reduced. So it did not show superiority over the ramipril. And if you look at the all-cause deaths, similar kind of a picture emerged. And we had hazard ratio of 0.88 in favor of ANI, but again, not statistically significant. And to summarize, this sacubitril/valsartan did not result in a significantly lower rate of CV death, heart failure hospitalization, or outpatient heart failure requiring treatment. And the pre-specified observations of reduction in both investigator reports or of the primary composite as well as of the total adjudicated events, so they were not seen to show benefiting with ANI. And the sacubitril/valsartan combination, safety and tolerability on one hand was similar to that of ACE. So we had a lot of interesting comments after this result came out. And if you look at the Medscape, it published that ARNI can't beat ramipril in patients with acute MI. And similarly, the TCT-MD, one of the headlines talked about that ARNI doesn't surpass ACE after acute MI. And then Medscape again had another headline that this particular trial, Paradise MI, makes me question the benefits of ARNI in post-myocardial infarction. And the ACC again showed that the ARNI did not outperform the ACE after myocardial infarction. And similarly, another HCP Live also talked about that it did not show statistical superiority. So here I would like to ask Dr. Shailendra Trivedi that after this particular trial result, has your practice changed in respect to patients with myocardial infarction, or it is the same? And how would you like to treat them?
Well, for this group of patients which are included in the Paradise MI trial, these are the patients who has had acute MI, and their ejection fraction was less than 40%. Whether they had pulmonary edema or not, but they were included in the trial. So I would say that these patients, if we talk about the indication for ARNI in these patients, ARNI traditionally we know that should be started when the patient is off the IV diuretic, should be off the inotropes, and should be hemodynamically stable. So we cannot start ARNI as early as we are starting the ramipril, and within first 24 hours, ramipril gives maximum benefit. So I think starting ramipril would be more safer in these patients rather than starting ARNI, and it gives long-term benefit also if you start within first 24 hours. And there are no restrictions like patient should be off the diuretic or off inotropes before you start this drug. So that gives an edge in practical terms to ramipril as compared to ARNI. Of course, when if we talk about the paradigm trial or other trials, then once the patient is stabilized, then it is different ball game, and then you can replace ramipril with ARNI. But to start with, I think ACE inhibitor would be my drug of choice for these acute MI patients.
Thank you. In fact, you have put it very nicely, and you have highlighted very important points that which do give an edge to start the ACE inhibitors, the ramipril, rather than the ARNI. And the 2 points which you highlighted was that if we can use it even if the patients is on are on the inotropic drugs. Now in this trial, they did not differentiate, and the investigator does not know who is getting what. And we gave that to take care of this. So all the patients who were stable hemodynamically, they were started in this trial. And you clearly mentioned, and I think all of us have huge experience now, that post-myocardial infarction, we want to start it early. That's the another point you made, that ramipril has evidence that if you start early, the benefits come much more. And we'll be, I think, talking about that also, that if we start ramipril early, the evidence is that within 24 hours, the benefits are more. And there is something to do with the tissue ACE level inhibition with the ACE inhibitor at the myocardium, which is in jeopardy at this time. And the ARNI, we are little worried regarding the hemodynamics, and preferably we wait. Regarding paradigm heart failure, it was altogether a trial which was done in the OPD when the patients were stable. So there we started with 50 milligrams and went on. Here we started early, but then evidence is there about Dr. Shailendra said, and I would fully agree with him. I would now like to ask my other colleague also regarding this. So let me ask him. Is my screen visible?
Yes,
No.
sir.
Okay.
Screen is not visible, sir.
Okay, I will just make it visible. Is it visible now?
Yeah.
Okay.
If you can make it full screen, sir.
Yeah, I'm going to do that. So we'll discuss that. And what do the guidelines suggest? So let's try and have a look at it first. So if you look here, the major clinical guidelines, the post-STEMI 2017 ESI guidelines for, and also both the ESC and the AHA, they are very certain that's class 1A. You have to give A's for STEMI with anterior location, ejection fraction less than 40, early heart failure if the patient has diabetes or hypertension. And you have class 1B for ARBs in the same setting. And Dr. Trivedi mentioned right in the beginning that if your patient doesn't tolerate ACE, then you can consider giving ARB, which is a very rightfully justified statement. Then we also have ACE inhibitor for all STEMI patients within 24 hours, unless contraindicated. We have class 2A, and the level of evidence is A. Now, the level of evidence A is quite significant. So here again, that opens up a window that almost all patients of STEMI probably would benefit, which is the evidence, if we start early. So if we look at the 2023 SC guidelines for management of ACS, what does it say? If you look at the beta blockers, then it is recommended in patients of ACS with EF less than 40%, regardless of heart failure symptoms, 1A. And similarly, for RAS inhibitors, the ACE inhibitors are recommended in patients of ACS with heart failure or with ejection fraction less than 40%, diabetes, hypertension, and or CKD. Again, it's class 1A. And for MRAs, we again have class 1A. So this seems to be very clear that all patients of myocardial infarction, we have to start on all these three drugs. And here ACE inhibitors have class 1A recommendation. The routine use of ACE inhibitors for all ACS patients, regardless of LVEF, like I said, it's class 2A and the level of evidence is A. If we look at the 2020 ESC guidelines for management of patients of ACS presenting without persistent ST elevation, then if we look at ACE or ARB, so it is clear you start with ACE or ARB if it is intolerant. And it's class 1A indication, and it is recommended in patients of HFrEF, diabetes, CKD. Now, HFrEF in this setting is not the chronic HFrEF. This is post-myocardial infarction, post-non-STEMI, you can say, and in order to reduce all-cause mortality. Here again, it's class 1A. Beta blockers again get class 1A, and MRAs again get class 1A indication in patients with ejection fraction of less than 40. So if we look at the review, the time-dependent therapies post-myocardial infarction. So this is a very nice pictorial which was published in JACC. And what it said was that if you have an index myocardial infarction, the immediate perfusion for ST segment elevation should be done immediately, and early revascularization for cardiogenic shock. So that goes without saying, as soon as the patient presents, you do that. And then the second step is early initiation of ACE inhibitors within 24 hours. 40% survival benefit from ACE inhibitor is conferred right from the first day. And it also says, if you look at 24 hours, avoid beta blockers for the first 24 hours for ongoing heart failure. And also, after 24 hours, early introduction of aldosterone antagonist. Benefit is time dependent. And again, it should be started within 7 days of index MI. And during this time, between 24 hours to discharge, you should reevaluate the eligibility for beta blocker therapy throughout the hospitalization. And after discharge, it is very important, critical, to titrate the dose of medications, including ACE inhibitors, to get them to the optimal levels. And here it's very easy. It's a simple two-step titration from 2.5 to 10. And in the follow-up, you can also ensure that the patients are taking the drugs and up to the target dosages. So the focus now is early ACE therapy initiation, up titration to the maximum recommended dose, which offers the maximum benefit, which again is a great advantage. And here, if you look, Jack acknowledges the AIR study, which was the first Trimipil study published in Lancet, and it showed significant survival benefit, 40% conferred on the first day of treatment. And here, the early initiation is important. We also have evidence from the other agents like the beta blockers. The early use within 24 hours of high-dose beta blockers is harmful and should be avoided in patients with MI with heart failure or high risk for cardiogenic shock, as age more than 70 years, BP less than 120, sinus tachycardia, heart rate more than 110 heart rate, or if it's less than 60. And we have evidence from 2 trials, Capricorn and Comet CCS2. ACE inhibitors, on the other hand, have evidence to be given right in the beginning, within the first 24 hours. And the ARBs are indicated only in patients who are intolerant to ACE inhibitors. And here, if you look at the evidence, it is only with valsartan and none else. No other ARB has been used in post-myocardial infarction. So this is something which is absolutely now crystal clear as far as the guidelines is concerned. So I come back to my another colleague, Dr. Gaurav. So in post-myocardial infarction patient, post-revascularization, at what systolic BP do you initiate the ACE therapy? What is the starting dose you recommend and how do you up-titrate? He can answer all these 3 at once.
Yes, sir. So generally, I would be comfortable starting ACE inhibitor therapy at blood pressure more than or equal to 100 systolic. And my starting dose most of the time, sir, is like 2.5 milligram ramipril per day, unless until patient is obviously having hypertension. If the patient has blood pressure more than 130, I would rather start with 5 milligram of ramipril. And what was the last subset, sir? Question?
I'll just ask you. The last question was that how do you up titrate the dose?
Yes, sir. Like in my next follow-up, generally after the discharge, next follow-up is after 2 weeks. So in my next follow-up, I would increase as per the BP tolerability of the patient. If the patient is maintaining good blood pressure, more than 100 systolic, I would just up titrate. So from 2.5 to 5 and then from 5 to 10. 10 I am rarely using, but up till 5 milligram, I am very comfortable.
Dr. Trivedi, what has been your experience of increasing the dose to 10? Do you think it is difficult or you can do it in most of the patients very easily?
Yeah, this dose up titration is a real practical problem issue in day-to-day practice, because the trials have used high dosages, and in the trial 10 milligram dose was the optimal dose, which has shown the benefit. But to be very frank, we rarely reach to that level, and most of the times patients are also reluctant to accept that increase in the dosage is not acceptable to some of our Indian patients, despite we try to convince them that this will give them more benefit. They think that they will have more side effects, and sometimes they get knowledge from chemists and relatives that why you are taking so much. This is true for statin dose also, and for true for ACE inhibitor also. Wherever you try to up titrate, there is a practical problem that patient's mind thinks that his disease is getting more severe. But yes, we have to uptitrate the dosage as far as possible, and maximal tolerable dose should be given if we believe on the trial results. That's what I would say.
So I will share my experience from participating in various trials over last couple of years. So starting from paradigm heart failure, and there, the only thing which we looked at, we did not know that whether the patient was on Enalapril or on Arni, and so we were looking at symptoms of the patients. And to tell you very frankly, I was very much worried because we had to double the dose. Well, the patient did not have symptoms. There were many patients who had blood pressure of just 100 and he had no symptoms, so we had to double the dose as suggested. So I was certain that they will come back with fall or something. But I was pleasantly surprised to see that many patients tolerated. So many times, it is also physicians' inertia.
Yeah,
And
correct.
we somehow, get carried away by patient attendants and all that. They are always counting the number of medicines we are writing and the dosages, like very rightly you said. But at certain point of time, I think it's many times our own fear in our mind, and we have evidence recently from strong HF also. So if you quickly do it fast, then probably patients would do well. In my experience, in the second, third dose, I typically go to 10 milligrams of Ramipral.
Mhm.
So I don't find after 5 any great hypotension happening. A once a day dose of 10 milligrams quickly. So this has been my experience, but let's take it forward. And so I come back to my friend Dr. Shailendra, that in post MI patient, post revascularization, when do you like to start a beta blocker? And which is your preferred beta blocker? I'd like to learn from him, which is his preferred beta blocker. And at what dose do you initiate and how do you uptitrate? And will you advise a combination of ACE inhibitor and a beta blocker in this particular subset?
So answering to the question that when do I start beta blocker, usually I wait for 24 hours to watch for post-MI, particularly post-MI, more so acute anterior MI, and for inferior MI, I have to watch for heart blocks also. So these are the two conditions where, because acute anterior MI is a large MI, so we don't know how the patient would behave within first 24 hours. So I wait for at least 24 hours before I start beta blocker. Second thing is, before starting beta blocker, I want my patient to be euvolemic. He should not be hypervolemic. So that is another point which I see. Then if patient is not in clinical heart failure, then metoprolol or bisoprolol or carvedilol, all the three drugs are good. But if the patient has heart failure, I would like to start with either bisoprolol or carvedilol rather than metoprolol, because these two drugs have, I think, in my mind, they have greater benefit uh, in these patients. And before discharge, uh, definitely I like to give combination, like not in combination, but usually I prescribe separately beta blocker and ACE inhibitor, so that I can decide at a later stage when the patient comes for follow-up that how much beta blocker is tolerating, how much ACE inhibitor is tolerating, and then we can give combined pill. So that is how I approach in terms of beta blockers.
Yeah. So I wanted a little clarification from you that what is your preferred beta blocker post myocardial infarction, revascularization?
If it's uncomplicated case, like I've done the primary angioplasty or thrombolized the patient is dead stable, then metoprolol
Okay.
is my first choice. Yeah.
Thank you. So I think we move ahead for the sake of time. And so this is something very important, that uh, we must use beta blockers, and we know it reduces the risk of sudden cardiac death and also left ventricular remodeling, other evidence than the RAS inhibitors. So let's look at the evidence of ramipril versus the other ACE inhibitors. So what is the evidence? So this is a very interesting study which was published in 2004. And it looked at the mortality rates in elderly patients who take different ACE inhibitors after acute myocardial infarction. And the idea was to look at whether it's a class effect or not. So about 7,500 patients, 30 days post-discharge till 1 year, they were studied. And it's a real-world study. And they looked at the various ACE inhibitors which were given: enalapril, lisinopril, fosinopril, ramipril, captopril, quinapril, perindopril. And all patients received the standard therapy. And what they looked at was reduction of mortality with the different ACE inhibitors. So if you look here, among the various ACE inhibitors, there are various ACE inhibitors: ramipril, perindopril, lisinopril, enalapril, quinapril, fosinopril, and captopril. And typically what you see, interestingly, the two ACE inhibitors, ramipril and perindopril, showed a significant benefit, which was not seen as much with captopril and also to some extent with enalapril. So what they concluded was that not all drugs within the class of ACE inhibitors should be considered to have same effect. And ramipril typically was better. It showed a significant lower mortality within first year of acute myocardial infarction as compared to the other ACE inhibitors. So now I would like to ask Dr. Gaurav that post-revascularization, if you find LV systolic dysfunction, but without clinical heart failure in your patient, would you put this patient on ACE or ARNI? Number one. Or in which scenario, there's a second question, would you directly advise ARNI? And in what dose do you use?
Sir, I would generally put my patients, almost all patients who have EF less than 40% on ACE inhibitor or ARNI, mostly on ACE inhibitors, irrespective of the clinical heart failure, because the data supports it. And we know that ACE inhibitors and beta blockers and the MRAs, they are the ways to improve the LVEF. And post-MI is a condition in which the heart is very dynamic and they respond to your drugs. And so often we see that in the next follow-up, the patient's LV is improved. So sometimes it's the effect of revascularization, sometimes it's the effect of drug, and we never want to miss the effect of drugs in these patients. And coming to your second question, in which scenario will you directly advise ARNI and what is the dose you usually use? So, sir, I'm a bit usually skeptical in starting ARNI in post-MI patients because these are fragile patients. Generally, I would give a trial of ACE inhibitors to them and see how do they tolerate. Because the patients, when they are in the hospital post-MI, the BP is different. And once they go home, the BP is different. And in our clinical practice, we have seen that so much rampant is the hypotension with ARNI group that I'm usually a bit scared to give it unless I am confident and the patient has followed up with me in the OPD. So if I have to give it to a patient, I would give it to a patient who is maintaining good hemodynamics, known hypertensive or presented in accelerated hypertension.
So I have another question. So when do you decide post-MI to give ARNI? Any subgroup of patients, or which subgroup of patients you like to give ARNI, or you would not like to give at all?
Sir, I'm not giving, sir.
So you're not giving. So you'll not like to give it. So the message is very clear. Good.
Yeah.
So let us look at the further evidence which we have. And here, if you look, we are very certain that it is the ACE inhibitors now after the discussions that which is our first choice and which should be started early. And here ramipril has clearly shown superiority in this particular subgroup we are talking about, which is the post myocardial infarction, and the another ACE inhibitor is the perindopril, but this comes after ramipril. If you have to use, you use these two. And the titration of dosages is also not very difficult, just two simple steps. You double the dose and you reach the target. So I have a common question to both the panelists for primary prevention. Now, this is not post myocardial infarction. So if you have a 55-year-old smoker and a diabetic hypertensive with elevated LDL but no heart failure or no left ventricular systolic dysfunction, will you opt for ACE inhibitor or an ARB? Now, this is something I would like to ask first Dr. Shailendra Trivedi. And clearly, in the HOPE trial, ramipril was used, and in the Europa, perindopril was used, and similarly, on target, valsartan and perindopril in ARB, not with the any other ARB. So, Dr. Shailendra, would you use for primary prevention also ACE inhibitor or an ARB? What are your thoughts on it? Which is better? I'll put it straight.
So this is sort of googly question.
Yes.
And from the trials data, there is not much of difference, no superiority or inferiority of either of the drugs. But if you say that the patient is a smoker and diabetic, then my inclination will be towards more ACE inhibitor rather than ARB, because ACE inhibitors, as far as my knowledge is concerned, in diabetic patients is better drug rather than ARB, and of course in smokers it is better drug.
Okay. What about Gaurav? What is your opinion for primary prevention, ACE versus the ARBs?
Sir, I totally agree with Dr. Shailendra. There is no clear preference in this situation. But yes, ACE inhibitors in the subgroup described by you would probably work more or would probably have more data to opt for. And much also depends on what all we have to give to the patient. For example, if I have to give 2 or 3 antihypertensive to the patient and I have to combine them, then more combinations are available with telmisartan and all. So sometimes it depends that way. But isolated single antihypertensive, if I have to give, probably I'll give ACE inhibitor to such a patient.
Okay, thank you. So I come back to the same slide because now there is a little twist, and I'll quickly take an opinion of both the panelists, and that is, this was a 55-year-old person. What about a young man, 35 to 40 years, which is a real life scenario we all see? Would you like to give ARB or ACE inhibitors? Just quick answer, Dr. Shailendra. If a person is little younger.
No, I think even then my preference would be the same.
Okay. And Gaurav, what is your preference?
Yes, sir. Age won't affect, sir.
Okay, thank you. So, typically the problem which I do see in our patients is that many of physicians, all of us, in fact, I include myself in that also, we are little worried about one particular side effect of ACE inhibitors, and that is cough. So if you look at the cough part, if you look in trials, with ramipril, it is 13% in trials, and in ANI, it is about 9.1. And if you look at the cough as being the reason for discontinuation, it is 2.3% in ramipril and 1.2% in ANI. So first, I'd like to ask Dr. Shailendra that what is the incidence in your practice for ACE inhibitors of cough? And the another part is all cough attributable to ACE inhibitors, and how do you manage it? Let's make it straight.
So incidence would be around the same what has been mentioned here, between 10 to 20%. And I agree that all the patients who complain of cough, it may not be related to ACE inhibitor. And first, we should try to convince the patient that if it is very minor cough, I usually tell my patients that try to tolerate the drug because it will give you benefit. And if you counsel them for some maybe 2 or 3 minutes, they may agree to continue with the drug despite dry cough. And if it is very discomforting, then I have to switch over to it.
Right. What is your opinion, Gaurav? How do you manage cough in patients?
Sir, first of all, the incidence is really very low. The figure given appears to be right, and it's always less than 5%. And I would switch over to some other antihypertensive only if it is a dry, long-standing cough, and other causes have been ruled out.
Okay. And if the patient you have given ACE inhibitor patient has cough, now what do you do?
Sir, I would change to ARP.
Okay. So this is something I'll also like to give my opinion. I think the incidence of cough is not less in my practice. It is about 20 to 25% some point of time. I'm not saying immediately. Maybe in the next few months, patients would develop. But I don't stop the ACE inhibitors. I always tell them that this would go away, try to counsel them that this is one of the effects because of bradykinin, which is something good for your heart. And I would never stop the medicine at the drop of hat. And interestingly, many of my patients, they would then start tolerating it also, and they continue to live with it. And if you have taken it off, then you can re-challenge your patient with this also after some time. That has also shown to work, although we all have our own ways of looking at things, and we all have different experiences. I think we have nearly reached the end of the discussion today. And to take it forward, I think we now have the last slide, and which is the take-home message. And it is in post-myocardial infarction with left ventricular dysfunction, ACE inhibitors have consistently shown reduction in CV death, all-cause mortality. In this scenario, ACE inhibitors seem to have a class effect. However, there is a data to suggest that ramipril will be a preferred ACE in patients of ACS and more so in elderly. Then we have evidence from Paradise MI, which was the first and the only clinical trial tested with great hope that ARNI would score over ramipril, but it did not do so in acute myocardial infarction. And another take-home message would be that the dose of ramipril, which you should try and reach, is 10 milligrams per day. And you can use it in any way, 5 milligrams PD or 10 milligrams once a day. I would like to thank both the panelists for the wonderful discussion and their insights today. It was really nice to be a part of this program, and I would like to hand it over to the organizers. But before I do that, I'd like to have one comment, single comment from Dr. Shailendra Trivedi, maybe his just closing remarks, and then again from Dr. Gaurav. Dr. Shailendra, what is your closing remark?
And I fully agree with the concluding slide. And the thing is, we should try to use maximum dose of ramipril to get the real benefits in our patients. That is very important.
Gaurav, quickly, if you can say, summarize your point of view in a single sentence. Yeah.
Yes, sir. So, sir, equally important is to realize that we have to start ramipril in almost all post-MI patients unless until it's contraindicated and it works for the patient.
So with this, I hand it over back to Dr. Anoop. If there are any questions which you would like us to take, just let us know.
So I think, sir, it was a wonderful discussion, sir. One question which I am seeing is, although not related, but the 4 pillars in heart failure, what is the correct way of starting and which is the first preferred, and how by what duration you will be able to get all the 4 pillars for heart failure patients, sir?
So I'd like Dr. Shailendra Trivedi, who has huge experience, to give his opinion first.
Okay. So I would say that out of those four pillars, three we have already discussed today. That MRA, ACE inhibitor, that is RAS inhibitor, and beta blocker. These three drugs we have already discussed. There is no doubt about all these three drugs. And the fourth also we should start before the discharge, unless there are contraindications or EGFR of the patient is low, or if you have a patient who has urinary tract infection, or usually in female patients, I would start this glyphosate group of drugs. But otherwise, at the time of discharge, patient should go home with all these four drugs.
Gaurav,
Sir, the recommendations say that we shall initiate all four of them, and probably all four of them together if the patient can tolerate.
okay. So this is a very interesting question, and I typically answer it in a different way. I like to say that whatever way you start, try and get all the four as early as possible. If the patient is not tolerating, try and get at least some dose of all the four. But there are two drugs which have also been talked about in various, algorithms. One very famous algorithm of rapid titration given by Milton Parker was that you start with SGLT2 inhibitor and beta blocker right in the beginning, because it would not cause any hemodynamic disturbance and would offer the prevention from sudden cardiac death right in the beginning, and no electrolyte imbalance, and then subsequently add the ARNI and then MRA. But we know whatever you do, the idea is to get all the four as early as possible. And the take-home message should be very clear. Start all four drugs in chronic heart failure. This is not for post-myocardial infarction. For post-myocardial infarction, we are certain that we use three pillars, and here is the preferred, and the beta blockers and the MRA. Both empagliflozin and dapagliflozin did not show superiority in reducing events post-myocardial infarction, although it did show reduction in hospitalizations for heart failure. So the message is clear. Post-MI, it's a different cup of tea. And also in chronic HFrEF, we start anyway, but get all four as early as possible. Well, it's been a splendid time with all of you, and we really enjoyed being a part of it, and hope to see my friends again in future soon. Over to you, Anup.
Thank you, sir. I think
Thank you.
we can just conclude the session, sir. It was a wonderful evening with valuable insights, sir. And thank you so much for your valuable time, sir. And I thank all the audience as well. And I don't want to be a barrier between you and the dinner. So thank you so much, sir. Good night.
Good night. Good night.
Thank you, sir. Thank you very much to all. Thank you very much, sir.